you guys so much for having me here. It's such a pleasure to be able to speak with you all today and tell you about cardiology, specifically sort of non-invasive and preventive cardiology. That's the type of cardiologist that I am. So I wanted to make this as interactive as possible and as applicable to you guys who are trying to kind of figure out what it is you want to do with yourselves and all that good stuff. So I thought we'd break the session up into two different parts today. I don't have a formal PowerPoint presentation. I'm just going to sort of cover a couple of different topics that I thought would be relevant. So the first topic I wanted to cover is just how to become a cardiologist. And in order to do that, I'll just sort of highlight my path. There's obviously lots of different paths to getting there, but I'll kind of review how I got there and my process and my journey. And then I'll also highlight a couple of other types of cardiologists that you can become. And then I wanted to open it up at that point to questions in terms of that specific aspect of sort of the path to becoming a cardiologist. And then the second portion, I thought I would cover sort of a day in the life of a non-invasive cardiologist. And sort of the typical pathologies that we see, the typical types of patients that we see, and that sort of thing. So why don't I start with my journey? So just very brief overview of who I am. I'm a general non-invasive cardiologist. I call myself a preventive cardiologist, and I'll get into sort of why that is later. And I've been in practice for 5 years now. I had a fairly traditional training pathway with some sort of nuances and deviations that I'll speak to you about. And then was in private practice actually for 5 years in New York, 2 different practices. And then recently relocated to San Francisco with my family for my husband's job. And as a result, decided to pivot a little bit and launch a preventive telecardiology practice. So I'm sort of a physician entrepreneur at this point, which is a little bit of a different path as well. So I'll touch on that briefly. So just to start, I guess I'll start kind of where you guys are now, which is my pre-med experience. So I went to Pomona College, which is a liberal arts college in California. So I was always interested in science and had this idea that I wanted to be a doctor very generally, but didn't have a good sense of exactly what that would entail or what kind of doctor I wanted to be. There was no one in my family that was a doctor. And so when in college, and it was a liberal arts school, so it's a slightly different kind of requirements and education, but I did enroll in the pre-med track. And one of the first classes you take is general chemistry, and I absolutely hated it, like absolutely hated it, did horribly in it, ended up dropping the class and said, okay, I guess I'm not going to be a doctor. It's not meant to be. But continued in my biology courses and absolutely loved them. And ended up speaking with my biology teacher who was like, you are like, biology is, you're great at it. Like, you should continue with this. Don't drop it completely. So we sort of continued with some of the science courses throughout and still had no idea what I was going to end up doing. Am I going to go get my MPH? Am I going to do public health instead? And then randomly really enjoyed organic chemistry. Like, I don't know who likes OChem, but for some reason I did. And so then ended up deciding that maybe I did want to be a doctor after all. And so I actually did go ahead and complete general chemistry over the summer, and then took a little bit of time off because I sort of was out of sync with my requirements, and ended up interning actually in the LA County Department of Health, and did a bunch of other things. So that's all a long story to say that that the path can look a little bit different. My training afterwards has been pretty straightforward and traditional, but I did do a 2-year gap between college and medical school, just because of the timing of when I took then general chemistry and then the MCAT studying and then the applying and all that. So, so for those 2 years, I was living in Los Angeles, and enjoying my time, and I actually worked at a Kaiser. I was a research coordinator for clinical trials and actually in oncology. So totally not what I am doing now. But also that helped me really realize that cardiology was something that I wanted to do. Medicine was something I wanted to do. So, the path can be sort of circuitous. It doesn't have to be straight lined. And I think there's more and more kind of non-traditional candidates. So taking time off is totally acceptable. And honestly, I think I'm a better physician for it. Not to say that you can't go straight through, and lots of people do that. But I will definitely tell you that many of my colleagues, as a result, I'm 2 years older than some of my other colleagues, but many people, because the journey thereafter is grueling. And so for me, having those 2-year breaks where I got to sort of enjoy a little bit of my 20s was really nice. So that was that part for me. And then I ended up at Boston University for medical school, and medical school, but I, enjoyed my time there. And then, so thereafter, in terms of the cardiology specific training, you then go to an internal medicine residency. And that's 3 years. And I did that at Columbia in New York. And then thereafter, I went to NYU for my fellowship. So Cardiology Fellowship is 3 years. So it's 6 years total in addition to after college training, or medical school rather. And then thereafter, some people do pursue further specialized cardiology training. So after the end of a traditional 3-year cardiology fellowship, you are a quote unquote general cardiologist. So there's other training that you can pursue if you want to be an interventional cardiologist, which is someone who performs catheterization procedures. And we can talk more about that when I kind of describe the cardiology fellowship experience. But if you choose to do that, that's an additional year or 2. You can even subspecialize. So you may have heard of the different valve procedures that people are doing now non-invasively. That's a structural interventional cardiology fellowship, and that's an additional year. There's also electrophysiology, which are cardiologists that put in pacemakers and perform electrophysiology procedures to get rid of atrial fibrillation, for instance. That's another 2 years of a fellowship. There's also advanced heart failure and transplant. So those are cardiologists who study very intensely heart failure and manage LVADs, which help patients who have very advanced heart failure continue with their lives while they're sometimes awaiting a transplant, or sometimes they're called destination LVADs, where they live their lives with these devices that are sort of mechanical support devices. So cardiologists learn to manage those, and that's an additional year or 2 fellowship. And then there's also congenital heart disease, which is adult cardiologists that then kind of manage patients who have congenital heart disease after they've been handed off by the pediatric cardiologists. And there's more and more patients that are, because the surgeries are so good now, that are surviving into their adult lives and need an adult cardiologist who's well versed in the complications, the unique complications that arise from these patients who have not only an abnormal heart to begin with, but have had a surgery at a very young age. So there's those type of cardiologists as well. I'm trying to think if I forgot any. I think that's most of and then advanced imaging, which, so most of us get a fair amount of echocardiography training within fellowship, but there's more and more modalities. And so if you choose to go into sort of an advanced imaging fellowship, you can learn more about how to interpret CAT scans, MRIs, and other more advanced modalities for heart disease. So that's the kind of typical different types of cardiologists you can be. And so just kind of going back to sort of my experience, In medical school, I actually thought I was going to be an infectious disease physician, which is kind of ironic given what's happening right now. And so I actually did a lot of international work and was really, really interested in that. And then just did a random rotation where I had a couple of patients who had heart disease and just became more and more interested in cardiology. And so, I think there's memes and there's different things going around of who ends up being a cardiologist. But I think it's true to say that most cardiologists are interested in cardiology because of sort of the diversity of experience within cardiology. There's so much that you can do. So you can be kind of a general cardiologist like myself who sees everything from, coronary artery disease, heart failure, et cetera, manage the stress test, things like that, to any of those other advanced sort of super subspecialized doctors. And I really was drawn to it because it's pretty fast paced, it's exciting, it's interesting. If you like doing procedures, there's a lot of procedures to do, and that was one of the main draws for me. Honestly, I loved all the procedural aspects of it. It's also I think the number one draw for me was probably the fact that it has such high impact potential. And by that, I mean that it's the number one killer of men and women in the world. And so for me, I was really drawn to the fact that I could have this massive amount of impact and really, really change lives and help improve them. It's also because it is the number one killer in the United States, there's just massive amounts of research and research dollars that go into cardiovascular health. And so it's rapidly evolving, and there's so much new data and research and information coming out daily. And so for me, I really enjoyed kind of the fast-paced nature of all the different treatment modalities that were coming out. So definitely someone who likes to kind of keep up with that and learn and is okay with kind of change. So those are kind of some of the reasons that I was drawn to cardiology. Columbia has a very strong cardiology department and is well known for it. So that also was a huge driver for me. And then, but I will say, then in terms of choosing fellowship, I knew, so also I think introspection is really important. And rather than staying at Columbia, which was a huge, it's obviously an amazing hospital, great program. But my perception was that very much focused on advanced heart failure, and then also research. And for me, I knew I wanted to be the strongest clinician that I could be. I was always interested in patient care. I like those long-standing patient relationships. And I knew I wasn't going to be a PI. I was not planning on doing any of that. So NYU was the right fit for me. So I would say also make sure you not only do introspection, but then have people that are going to advocate for you to help you find those positions. So the physician I was working with at Columbia, I asked her to call NYU and make sure they knew that it was my top choice. So that was out of my comfort zone for sure. But if you have, I would say that's another big piece of advice for me is figuring out what you think is best for you, not what is the best choice, and then making it happen by asking and by pursuing it a little bit more aggressively than maybe you're comfortable with. So landed at NYU, and it's just a quick taste of what fellowship is like. It's grueling. It is tough. It is hard. But it is not what your life as an attending will be like. And so I just knowing that is important, be ready for hard work. I'm sure any fellowship is like that, but cardiology is intense. And there's a lot to learn. So I felt like that was the biggest learning curve by far for me, was that transition from residency to fellowship. Because you go from being sort of the doctor that's kind of learning the basics about everything to now you are the consult, right? And so you're used to calling calling for the cardiology consult. And then all of a sudden the next day you are the cardiology consult. So it's definitely a lot to take in, both in terms of your transition to becoming the kind of ultimate expert. You're supposed to be the ultimate expert. And then also there's a lot to learn. So in Cardiology Fellowship, you have a bunch of different rotations. So you learn how to interpret and perform an echocardiogram, which is a sonogram of the heart. And so you're required to not only know how to perform it, because you are the person who performs it overnight if there's an emergency, and then you also need to independently interpret them, and you have to learn that quick. So that's a huge learning curve, but exciting. It's really fun, and one of the reasons I was drawn to cardiology. So the different rotations you do. So echocardiography is you do a couple months of that. The cath lab is another rotation you'll do. So you'll be in that for a couple of months. And that's where you learn how to perform angiograms, mostly coronary angiograms. So putting dye into the arteries of the heart, taking pictures, looking for blockages, and then learning how to intervene on them by placing stents if there's blockages. There's also, as I mentioned, structural heart disease, which you'll get exposed to, doing valves, in valves, as well as clips, and then peripheral procedures as well. So peripheral arterial disease and things like that. There's the electrophysiology lab that you rotate through for a couple of months. So learning how to diagnose and properly treat arrhythmias, pacemakers get put in. And then the big one is learning how an electrophysiology procedure is done. And then you also rotate through the stress labs. So learning how to do stress tests, which is a big part about being a cardiologist. So stress tests is where you help diagnose whether or not there might be blockages in the arteries. That can be done either through putting people on a treadmill, and having them walk and eventually run. And then you take pictures before and after with a sonogram, or you can also simulate exercise with medications, and then use nuclear medicine to take pictures that way. So you rotate through that, and then you also rotate through the CCU, which is the ICU for heart patients, and you learn how to take care of very advanced patients. So lots of patients after massive heart attacks, lots of patients who are sort of in the end stages of heart failure and need medications to help their heart continue to pump, or mechanical assist devices, all kinds of stuff. And then you also obviously rotate through the clinicals, which is where you learn to manage kind of bread and butter kind of cardiology. So that's fellowship. That's 3 years. And then after that, you are an attending. And so just to give you a quick idea of the different sort of things to consider, and true of any specialty, is whether or not you're going to go into private practice or whether or not you're going to go into academics. In terms of academics, many people are investigators, so they're very dedicated to research. Others are more clinical educators, so work more closely with the programs to educate residents and fellows. And or become increasingly, there's now a position that's like a hospitalist, but for cardiology. So just doing kind of inpatients and things like that. So there's different paths. I ended up choosing private practice for a number of reasons, and I can get into that further if that's of interest. But I wanted a lot more autonomy than often academic positions afford. And I wanted the ability to work part-time, which is quite difficult in an academic setting. I have now 3 small children, and a husband who does a ton of work as well. And it's not something I ever thought would be part of my decision-making process when I was in college, that's for sure. But priorities do change. And so for me to have that flexibility has been really, really key. And so you do have a little bit more ability to pick and choose hours and things like that when you're in private practice. The trade-off being is that there's, I always thought I would be a physician educator, and I have less exposure to kind of educating residents and fellows and things like that. Although there are some private practices that have a relationship with the various universities to try to continue to do that. So it's not impossible in private practice. And so that's kind of a big sort of decision tree. And then thereafter, the other big decision tree is just sort of how, if you want to do any further advanced training, or if you want to just sort of stick with being a basic non-invasive cardiologist, which is what I wanted to do. And then you take boards. So there's a lot of boards. Be ready for that. The tests never end, my friends. The tests never end. So in order to be a cardiologist, you need to be boarded in internal medicine, cardiology, and then I would say to be employable, you need to be boarded in echocardiography, nuclear medicine as well. And then I ended up deciding to also get boarded in clinical lipidology, simply because of my interest in preventive medicine, in order to sort of make myself stand out and have further training in that. So that's sort of kind of the basics of how to become a cardiologist, the nuts and bolts, kind of the dry, boring stuff. So let's maybe pause here, see what questions you guys have, and then keep in mind, I'm going to come back and sort of talk about a day in the life. So kind of my typical day, the types of patients I see, the sort of, and I'll just a super brief overview of the types of patients I see and the diseases I treat commonly and that kind of stuff.
Yeah, so there was a ton of questions so far.
I saw them rolling in. I was like, oh,
so we'll go through a few right now, and then we can do the second part and finish off with just a general Q&A. So some of the questions that we have so far, a lot of them are due to undergrad. And one of the questions was, how do you feel about those of us who are in liberal arts colleges or with liberal arts majors? Do you think that is a deterrence, that's a bad thing, or do you think that offers a different perspective on applications that medical schools will like?
I think it absolutely offers something different. I think it's, it definitely, and it depends, I'm sure, on the school and how well prepared you personally are. For me, I definitely think I had a little bit less guidance in terms of, okay, I didn't like GChem, so I just dropped it, and then so I fumbled around a little bit. I did. It obviously all worked out in the end, and it was fine. I think, at liberal arts schools, it's a little, at least my personal experience, it was a little bit harder. And like some of my friends that wanted to be a lawyer and things like that, like those pathways aren't because the focus of the education is on being more well-rounded. It felt a little bit less hand-holding than maybe I would have liked to kind of get on that pathway. But absolutely, in terms of your application, I think it's been fantastic. I think medical schools really, the emphasis is on having a well-rounded background. I think anything you can also do above and beyond, for cardiology in particular, research is huge. It just is. So when I was in residency, once I figured out I wanted to do cardiology, I, quickly went to my chiefs and said, hey, I'm interested in, this is kind of I don't want to be a researcher. I'm not interested in lab work. Like can you find me a mentor? And they were able to find me a mentor who had kind of preventive focus, like I knew I would be interested in. And so I was able to find research that, even though I'm not a researcher, was interesting to me and felt relevant to kind of what I wanted to do. So that would be my other piece of advice, is particularly if you're coming from a more liberal arts background or something like that, is if you think you're interested in cardiology or really any of the competitive specialties, is getting a mentor and doing some research as soon as you can, because being well-rounded and having all these other interests is super important, but definitely research will always be important.
That's great. That's really good to hear. A lot of people were happy to hear that having a liberal arts background is not a bad thing necessarily.
It's not.
Another question that someone asked was, have you found that it's difficult running your private practice without a business background? Do you think that having a business background would help you in any way or be beneficial?
That's a really good question, and I'm so glad you guys are thinking about that. So more and more physicians are becoming a little burnt out from so there's kind of been this sort of transition, right? So a lot of physicians, maybe like 10 years ago, were super interested in like these employed positions. Great, I don't have to worry about the business aspect. And we're now seeing that other side of the curve, where my generation of physicians is going, wait, what a second, I'm not in charge anymore. I went through all of this training, and yet someone who's has a lot less education is making all the decisions. So certainly a lot of, and burnout's a huge thing right now that we could talk about as well. So more and more doctors are realizing that they do want to have that autonomy back, and they want to be in charge. It's difficult, but I would certainly say a business background could be very, very helpful. And I do wish I had more of a business background. That said, you are smart people. You can figure it out. So even if you don't get a traditional, get an MBA or do some sort of traditional business training, which I don't know that you need, you can read and learn and study up, and you can figure it out. And that's what I've been doing. I've been sort of bootstrapping it along the way. And I have to say, much like this program, there's so much new and cool stuff that's coming out with social media that can network and connect you with people that are doing similar things. So there's lots of physician Facebook groups. So if you're not on Facebook at some point, you might want to be just for the groups, because there's a lot of physician Facebook groups. There's a women's private practice Facebook group, and we shoot ideas off each other all the time about hiring and firing, about this and that, finding medical malpractice insurance, all that stuff that you will not learn in medical school. And you can kind of figure that out along the way.
Great, thank you so much for answering that. A little earlier on, there's a bunch of people just kind of asking about your international work and what that was like, and just kind of more what kind of travel and how was it really?
Yeah, so let's see. So between college and medical school, I actually, right before I went to medical school, I ended up spending 3 months in Ecuador just teaching English. Not a medical thing. But then, and that's sort of, and I just wanted to do that. I just wanted to do some volunteerism before I went to medical school and got busy again. And that definitely sparked my interest to doing more international work. So if that is of interest to you, there are definitely programs that do that. And I've had, so BU was great with that. I spent the year between my first and second year in Uganda doing you're not a doctor yet, so it's kind of, we were doing more like medical research and helping out an NGO at that point. So I did that. And then when I was in medical school, like towards the end, once I was like a third and fourth year, most schools, that's kind of when you have a lot of elective time. So I did a ton of international stuff at that point. So I did my neurology rotation in Chile. I did, and then I did like a bunch of other rotations. I did a pediatrics rotation in Nicaragua, and did a lot of like clinical care there. So it's definitely doable. Certain programs, I think UCSF has a lot of that as well. So if international work is of interest, I would definitely look at that when you're looking at medical schools and then residencies and things like that. And then I did do some further work afterwards. So that lends itself, and I think any sort of specialty, you can do some international work. Definitely a lot of the surgeons do a lot of international work. It's something I want to get back into again once my kids are a little bit older.
Of course. A lot of people are actually asking about what you feel like some of the pros and cons are of cardiology realistically, and also just knowing that this is a male-dominated field, we know that you want to talk about that. So a lot of people are asking about that as well.
Yeah, absolutely. So I was going to cover that later, but let's just cover it now. Why not? So in terms of the different things to think about, so I think I covered all the reasons why cardiology is exciting. So there's a lot of them. It's really fun. It is. In terms of some of the things to think about that are some of the downsides. So it's not necessarily a downside, but definitely something to know is that it is very male dominated. And so it's like 12, maybe it's now 13% of us are women. And so I personally had a great experience when I was at NYU. Half of my fellowship class was female. I think NYU is pretty unique in that sense, but it's becoming, it's better and better. There was also a fair amount of cardiologists who were women who I could look up to as mentors. I will say in terms of women that are practicing cardiologists that are married with children, not as many, just to be completely realistic, just to be completely honest and open. That I think was definitely a concern for me. When I was just to be completely honest, when I was in college and medical school, I really was not sure that I needed to get married or have kids. I was just not that person. And then when I did meet my husband, I was like, oh, okay, this is why people get married. So definitely having kids and medicine is harder for sure. And so I had my first kid when I was a fellow. And the fellowship, as I mentioned, is very, very grueling. Tons of call, and our call's hard. I mean, we're coming in for STEMIs, we're coming in for, echoes on patients that are potentially in tamponade. I mean, it's emergency after emergency after emergency. And so you were just wiped. So it's definitely a lot of work, and having kids is a lot of work. And so there's not a lot of sleep that happens. And realistically, a lot of, the child rearing just falls on women. But it's totally doable. Again, I think if that's of concern to you, ask around. There's definitely some programs that may not be as female or family friendly. You'll also get a hint when you interview by the types of questions people ask. And then just really start trying to connect, I think, with other women that are in cardiology or in medicine in general. And again, social media is fantastic for this. Get on Twitter. There's so many different ways that you can access mentors outside of the traditional pathways now as well. And you can feel supported that way. And again, though, I had a great experience in the sense that I felt very supported in my program. I was one of the chief fellows in my fellowship. I had a really supported professional relationship with everyone there. A lot of he for she. I mean, it was good. What I would say is where the bigger sort of disconnect is the patients, to be honest. You more often than not get mistaken for someone other than the physician. And that's just the reality of being a female in medicine. And you feel like you have to know more and work harder to prove yourself. But I think there's just so many mentors now and just so much out there in terms of support that, and cardiology you can even be an interventional cardiologist. Tons of very successful women doing it. It's hard work, and you've got to get the right support system and the right balances, but definitely, I think the biggest cure for burnout is finding something you're passionate about. So if you're passionate about interventional cardiology or anything within cardiology, you can make it happen. And that's I think the best way to make sure that you won't burn out. So don't let any of that deter you. Just find the right support system.
That's great. Thank you so much for your honesty and sharing with us.
I'm totally being honest here. No one that's me.
A lot. I think we can probably go on now, and then at the end, we'll save all these questions and answer any new questions that we have.
Okay, yeah, it looks like we've got, okay. So let's cover kind of a day in the life of a typical non-invasive cardiologist. So part of what I loved, as I said, about cardiology is kind of the diversity of your experiences. And that goes for just even the diversity of your experience within the day. And that was a huge draw for me as well. It's rare that as a cardiologist, you'll just be, I mean, there are some, but it's rare that you'll be just sitting around doing one thing all day long. So for me, that was really exciting. So a typical kind of private practice cardiologist depends if they have hospital coverage programs or not. Some private practice physicians don't and some do. I would say it's kind of mixed at this point. It's becoming increasingly common that one of your colleagues who is a strictly hospital-based cardiologist will cover any of your patients in the hospital. So if that's the case, then you don't round at the hospital. If you don't have that relationship, then most private practice cardiologists of day will start off in the hospital, round on the patients that are inpatient of their patients, and then go to clinic. And then once you're at clinic, different practices structure it in different ways. I have a very non-traditional practice right now, so I'll kind of pretend I'm still at my other practice, but at my prior practice in Manhattan, I would get in, see a bunch of patients, and then we would do testing sort of throughout the day. So when Echo Tech is doing echoes on my patients that I've ordered over the week, and I read those in between patients, typically see somewhere between, just depends on the day. If you have a lot of studies that you're supervising, less patients. If you don't have that many studies, I would say somewhere between 25 to 35, 40 patients a day is pretty standard. And it depends on complexity. It depends how many new patients, how many olds. So I'd get about 40 minutes with an old patient, 20 minutes with a new patient, give or take. And then there's always tons of overbooks and things like that. And then the rest of the day, you're just running around in between seeing patients. You supervise stress tests. So most private practice physicians have nurses or supervise themselves the Bruce stress tests, which is where the patient gets on the treadmill and exercises under supervision. And then with the echocardiographic images before and after. We also interpret, obviously, all of our own EKGs. We interpret all of our own cardiac monitors. So there's Holter monitors, which monitors the patient's rhythm for 24 to 48 hours. And then there's also these longer term monitors that patients can wear for 2 weeks and sometimes 4 weeks. So we get those monitors that we read, and those are where you're looking for rhythm issues. Patients that are experiencing syncope or palpitations or something, and then you can read. A lot of patients or a lot of cardiologists are starting to do their own vascular studies. So I was reading my own vascular studies as well. So carotid ultrasounds, DVT studies looking for blood clots, that kind of stuff. So lots of stuff that you're running around doing. No day at all looks the same, which I've really liked and enjoyed. So just to kind of briefly cover some of the classic sort of patients you'll see. So as a general cardiologist, you are often the gatekeeper for all of heart diseases in general. So classic patients would be just, stable coronary artery disease patients. So patients who have known blockages in their arteries, and you're responsible for their medical management and helping them prevent another heart attack. So you would manage their medications, and then if there was new symptoms that were concerning, then you would be in charge of trying to figure out what those are from, whether they're from their heart or something else. So typically at that point, you'd order different diagnostic tests that you would then supervise and interpret, and then decide your game plan thereafter. If a patient has a new blockage, then that you felt needed to be fixed, then you would call one of your interventional cardiologist colleagues at a nearby hospital and present the case to them and tell them, you wanted them to get stented and studied. And what's great is that, especially if you end up working in a city where you trained, is your go-tos, and and then you're very much involved in the conversation. So typically, if I refer a patient for a cath because I'm very concerned about the symptoms, it's unstable angina, then I would refer them directly to the cath lab, call up my colleague. they would do the study, and, they would send me pictures, and we would chat about the lesion, and, so there's a lot of back and forth and working with the interventionalist when it comes to those kinds of things. And then there's heart failure. So that's broadly broken down into systolic heart failure, which is failure of the heart muscle to pump blood to the rest of the body. So their ejection fraction is low. And then there's diastolic heart failure, which is even more complicated and annoying, which is where the heart muscle broadly doesn't relax properly. And so the medical management of those diseases are very, very different. But essentially your goals are obviously to help them feel better, live longer, and be able to do, their daily activities. So those are patients that there's an increasingly large number of medications that you can use to manage them, both to improve their long-term survival and then help them feel better. And so those type of patients sometimes are super stable, and you see them every 6 months or every year even, and they're fine. And then you have other patients that you're managing very, very acutely chronically, and so they'll call you up with weight gain or shortness of breath, and you have to be able to titrate medications either over the phone or bring them in. And so those patients can get complicated, and then at some point you may decide to hand them off to your advanced heart failure colleagues. So you're in charge of sort of deciding when that care, they need the next level of care, which is typically you're concerned that they need to start getting evaluated for an LVAD or a heart transplant. When things like their kidneys are getting worse, they're not responding to their usual amounts of diuretics, they're landing in the hospital more, that kind of stuff. And then arrhythmias is another big one. So you'll get lots of consults for palpitations and things like that. By and large, they end up being kind of just benign, but we pick up lots of atrial fibrillation and different arrhythmias. Supraventricular tachycardia is a super common one in young people that you'll pick up frequently. So teaching them how to either, if they have infrequent symptoms, how to manage it with different maneuvers, which is always fun to teach people how to do, or if they're having frequent symptoms or they've passed out or something like that, then you refer them to your colleagues, your EP colleagues. So that's another case where you get to call up a colleague and tell them that someone needs a procedure. So, or, someone's an older person's passing out, and you do a Holter monitor on them and they're having a 10-second pause or something like that, then you call them up for a pacemaker. So those are those type of patients. And then, let's see, and then we see valvular diseases. So, so very frequently aortic stenosis is probably the most common valvular disease you'll see, which is thickening of the aortic valve, which is the main valve that heads out of the heart into the body. So we see that a lot. And so the general cardiologist's job is to, one, diagnose it. If it's mild or moderate or not causing symptoms, your job is to follow them and follow them closely, because you want to catch them just at that point where they would need surgery, and then you refer them to your surgical colleagues or the structural interventionalists, depending on the age and comorbidities and things like that. So those are fun patients to follow once that gets picked up. Say you pick someone up with moderate AS, then you'll follow them at specific intervals, perform stress tests. Sometimes it'll be severe and the gradient's huge, but the person swears they're asymptomatic, so you have to prove that they actually are, or whatever else. So there's a lot of clinical decision making that comes into play there. What else? And then we also see, so congenital heart disease is another one. While there are obviously congenital heart disease specialists, we see a lot of kind of the more basic heart disease, congenital heart disease, like say bicuspid aortic valves is a common one that a general kind of cardiologist will follow. So those are kind of some of the more typical things that we kind of follow. There's also, pericardial disease. So we'll see pericarditis, which is inflammation of the heart sac. That's not that uncommon in young people. Different diseases of the aorta and peripheral arterial disease. And then lots of bread and butter cardiology is also just not even heart diseases yet, but sort of resistant hypertension. So patients who have really high blood pressure that needs to be better controlled. As a lipidologist, I end up seeing a lot of patients with familial hyperlipidemia or other sort of cholesterol metabolism disorders that is kind of beyond the scope of a general internist or even other cardiologists. So there's just so much that we see. And then there's tons of patients that have symptoms and don't have any disease, whether it's chest pain or shortness of breath or palpitations. And your job is to sort of sort that out. Is this cardiac or not? And then if it's not cardiac, who should they see to kind of continue the workup? So lots of variety, lots of things to do. Definitely never boring. I'm trying to think what else I should cover. What time is it? Oh, it's getting late. What else? What other questions have come in that we should? Any other burning questions?
There's a ton of questions.
Okay.
One of the questions that we just recently got that a lot of people seem to be very interested in is, as a cardiologist, and I mean, now we're nearing like month 9 or 10 of COVID, what have you seen patients that are having long-term side effects because of COVID? And if not, or just based on your professional opinion, what do you think those side effects later on in the future could potentially be?
Yeah, that's a great question. So the cardiology community is still sorting through all of this, but we certainly are seeing a lot of concerning symptoms that may be related to certainly to sort of this long haul COVID. Definitely one of the most concerning aspect of COVID with regards to the cardiovascular system is definitely some of the clotting disorders that we've seen, the strokes in young people, things like that, but then also the COVID myocarditis. That's where, and we see, so myocarditis is an inflammation of the heart muscle. We do see it with other viruses like the influenza and rhinovirus and other viruses. And we definitely are seeing it with COVID. And so one of the biggest concerns there is in terms of, so if you diagnose someone with myocarditis, because of the inflammation of the heart muscle, that person is at increased risk for rhythm issues, particularly lethal ones. And so the recommendations typically are sort of, it's not bed rest, but no major exertion for 3 to 6 months. And then we do a lot of testing to make sure people seem like, they're recovered and should be good to go. And so certainly with this many people who've been exposed to COVID, sort of the return to play guidelines and a lot of kind of what we might see, it's definitely an important cause of sudden cardiac death in athletes in non-COVID times. And so we do worry about, not only athletes, but just, your average Joe who wants to go on his run again, what that might mean for people in terms of exerting themselves and things like that. So, and then definitely some POTS-like symptoms. So a lot of autonomic instability we've seen. That's a whole nother talk in of itself, but essentially we can see that after some viruses, and we're definitely seeing it after this one, where people's heart rate remains quite high and they're and they feel kind of lightheaded and unwell in an upright position, and that's definitely something that we've been seeing as well.
Great. Thank you so much for telling us that. There was a lot of uncertainty, so we're glad to have some of it cleared up.
Yeah, I mean, it's going to be one of those things that we're going to be learning about it for years, but that's sort of where we're at right now and our understanding of it right now.
Great. There was another question that Karina had, which is a really good question. She asked, how do you deal with patients that you treat but continue to make unhealthy lifestyle choices and then rendering their treatment ineffectual, and just they keep coming to you with the same issues and nothing seems to be working?
Yeah. So definitely as a preventive cardiologist, that is a big one. And it's definitely frustrating. And it's something that you'll, no matter what sort of field you go into, you'll see. And so I think a lot of learning to be a doctor. So that's where the art of science, of doctoring comes in, right? So trying to figure out where that person's coming from and what are the barriers to change. And so these are, again, some of the softer skills that we sometimes learn in medical school to varying degrees, but really you learn mostly outside of training, and just build up your experience. You know, we learned some things like motivational interviewing and things like that, and there's definitely habit change science, but a lot of it I found is really, you know, trying to figure out where the patient's at, and what are those reasons that they're finding it difficult to make a change. And unfortunately, there's definitely some patients that, and you'll learn about this kind of where they are in the, especially with regards to smoking, right? So you'll learn about, are they contemplative, pre-contemplative, that kind of stuff. And so some of those things apply as well. So if they truly are just not ready to change, then you have to do your best not to take it personally, and continue just to forge and continue to provide them information in a very non-judgmental way. But many times people are in that sort of ready to change, but don't know how and just don't have the right tools. And that's where it's your job as the clinical educator to figure out, meet them where they're at. You know, you're not going to make someone who's eating red meat 24/7 all of a sudden become a whole food plant-based patient. You're just not. So figure out where they're at, where can they make small changes, and work with them, try to help them troubleshoot, and kind of using those techniques. I've had really great success. Not everyone though. You just can't fix everyone. But trying to reach the people you can is it's really rewarding when you do. And you definitely, that's part of what I love about cardiology, is you really do see these dramatic changes sometimes. And sometimes the patients you least expect to make those changes will, and it's incredible. So stick with it. Don't take it personally. Do your best with every patient encounter, and you're not going to save the world.
Great. That was very inspirational. So thank you for that. There was a question that a lot of people wanted us to ask is, when you encounter frustrations, how do you disconnect that and not bring that into your home life? And especially maybe if they're a little bit more like dire cases or something that will particularly hit you a little bit harder than others. How do you not take that home and bring that into your family life?
That's a really good question. It's really, really hard. There's definitely going to be, and all those cases are running through my head right now. There's definitely going to be cases throughout your career that will impact you in really profound ways. And that's just part of being human. And that's what makes you a really, really good doctor. It also, as you said, makes it really hard to then come home and be present to your family. And so kind of being honest with yourself and where you're at, and that's where having a team at home is helpful, and a community that's helpful. So whether you can go for a quick run after work, or just quickly hop on the phone with someone and vent or decompress before you get in, it can be really helpful. And then just letting yourself feel it. I'm that doctor that cries with my patients. I don't suppress it. And I think that patients respond to that really well. And I still will never be able to pronounce someone and not have a moment with the family and cry those tears together. That's just not the kind of doctor I am. And I think, I've never had a patient's family member be like, that was so unprofessional. Family members really, it's cathartic for you as the doctor, but then also I think the family members just respond to it because they realize how much you've tried and had those moments together that show that you're human and you care deeply. And I think kind of just not suppressing it and letting it just be you is really helpful to then not bring it home to your family.
Great. So I think we're getting close to the end, so maybe we'll ask 2 more questions. Okay. So a lot of people throughout the entire session have just been wondering about how you believe telehealth, especially right now, has impacted your work and, the pros and cons of it. But also someone particularly wanted to know, do you think it would be more useful for people in more rural areas who might not be getting cardiovascular critical care?
Yeah, great question. So I obviously believe in the power of telemedicine, as I've just launched a fully telemedicine initiative. So I think telecardiology is definitely an untapped sort of powerful tool. It is not a complete and total replacement for all cardiovascular care. So there are definitely moments where I will not feel comfortable treating a patient with telemedicine because they absolutely need a physical exam. So for acute concerns, telemedicine isn't a great solution. You need to be able to put that stethoscope and listen to their heart and their lungs and feel their skin and all those things. But I think for chronic disease management, it is how we should have been doing it for some time. Patients, particularly if you're trying to affect behavior change and focus on different lifestyle measures, like there's no need for them to trek into the office and wait and park and all this stuff. And there's a really unique aspect of being able to see a patient in their home as well, and their home life. And it lends itself to a slightly more casual encounter, and patients can open up more. And then you can just see them with more frequent intervals. So I think telemedicine is fantastic for chronic disease management, and I think is certainly the way of the future. I think a good portion of our follow-up visits should always probably have been telemedicine. For like the heart failure patient or something like that, I mean, there's definitely lots of times where you need to see someone in person. I would never feel comfortable seeing someone with acute chest pain via telemedicine. Like, it's just not going to happen. And at least until we have a lot different technology. So I think it's really powerful and has some really unique benefits, certainly. And then there'll be other times where we need to, lay hands on patients as well.
Great, thank you for answering that question for us. We definitely do feel that telemedicine and all things virtual are definitely the way of the future.
Absolutely.
And so I guess we're right about finished. So the last question that we have for you before we go is, what last piece of advice would you leave us pre-med students with, especially now dealing with COVID and applying to med school, finishing our courses and things like that?
That's a really good question. I mean, I feel like I've sort of, a lot of my typical advice, I think I've mentioned throughout, but I think just in terms of COVID and sort of where medicine's at right now, I think that for anyone kind of going into medicine right now, I think that this experience has certainly revealed or made even more plain the issues within our healthcare system, and from so many different levels, not just physician dissatisfaction, patient dissatisfaction, disparities in care. I mean, you name it. It's been all laid plain, and so I think a consideration of where the physician fits into that model is going to be really imperative for any physician in training going forward. And so I think you guys are getting a little bit more, definitely when I was in training, I was straight ahead, pass my MCAT, now pass this, now, and I think there's so much changing in medicine whether it's medical technology and all the different things that are, from a digital health perspective, to just the insurance-based model and how no one's happy with it. I think there's a lot that's going to be changing within medicine in the next 10, 20 years. And so being part of that change as future physicians is going to be huge. And so the more you can kind of learn about that and participate in that change, I think the better off we all will be.
Thank you so much.
Thank you so much.
Someone mentioned that they could really tell how genuine and passionate you were just through your voice. And we completely agree. This was amazing. Thank you so much for sharing.
Oh, good. I'm so glad. I do, as I said, I love, talking about all this stuff. I think it's so exciting that you guys are doing this initiative, and I'm really grateful I had a chance to be here. So I'm on Instagram, obviously, which is how you guys found me. I started the account fairly recently, but I've really been enjoying it. So if you want to learn, so it's mostly a patient forward account, just kind of to help patients sort of learn more about both cardiovascular disease, nutrition science, and lifestyle, true evidence-based lifestyle modifications. That's sort of my platform. But yeah, if you want to find me there, Nicole Harkin, MD.
I'll go ahead and type it in the chat for those who need it.
Cool.
So thank you so much.
Thank you.
Absolutely. It was such a pleasure. Thank you so much for having me.
We hope you have a great rest of your night.
You too. Bye.
Happy New Year. Thank you.
Happy New Year.
You too, guys.